Welcome to our podcast episode on external quality assurance, or EQA, for testing biomarkers in oncology. I am your host, Anna Christofides. We are very excited to welcome our esteemed guest for this episode, Dr. Emina Torlakovic. Dr. Torlakovic is a Director of Canadian Biomarker Quality Assurance and a professor in the Department of Pathology and Laboratory Medicine at the University of Saskatchewan. She is also a division head of Hematopathologist. Dr. Torlakovic is also a founding member of NordiQC, Canadian Immunohistochemistry Quality Control, Canadian Biomarker Quality Assurance, and CBQA Readout Program, as well as the International Society for Immunohistochemistry and Molecular Morphology. She also chairs the Canadian Association of Pathologists National Standards Committee for High Complexity Testing. Today, we'll be discussing the use of EQA to aid in the improvement of biomarker testing in Canada. Hope you enjoy it. So thanks so much, Dr. Torlakovic, for joining us today to discuss the importance of external quality assurance, or otherwise known as EQA, in the development and improvement of biomarker testing in Canada.
Thank you for the invitation. I'm very happy actually to be here to discuss this important topic with you.
Great. So to begin with, I just wondered, how has the evolution of personalized medicine impacted this area of biomarker testing in Canada?
Well, hugely, because obviously there was lots of biomarker testing before personalized medicine. And where is the actual event historically when this all started is hard to say, but maybe it's fair to say that personalized medicine started, at least from the pathologist perspective, with testing for breast cancer for estrogen and progesterone receptors. So hormone receptor testing, that kind of bridged this era for pathology world and introduced really slowly what is to come, because for years it was very limited, hormone testing, HER2, very little else. And then suddenly the development of molecular medicine triggered this tsunami of new biomarkers that are all important. So at the impact of that for medicine is huge. I mean, it is the impact is the greatest actually for patients and their outcomes. So that's wonderful. So that's why the rest of us who are involved in biomarker testing have to make sure that we are doing the best possible job. And how this changed, it's not only that it changed like how many biomarkers we test, it changed also our aspects of what quality testing actually is, how it is defined, and how we look at quality assurance for biomarkers, as well as some of our concepts. It changed definitely. This is the area probably where it changed the most, and the one that is least understood by practicing pathologists, oncologists, like anybody, that it changed our concepts about what is quality, how we do it, and what I actually test. What is biomarker testing? This whole idea has changed. Mm-hmm. It's kind of a little bit complex now, so we cannot squeeze it all here in our discussion, but that is probably the most important area where it changed how we do things.
Yes, that's a lot for everybody to learn in this area with all these changes. And so what is external quality assurance? Can you give us a kind of description of that and how it relates to improving the quality of biomarker testing in oncology?
In the quality world, of laboratory medicine, we do have two aspects. One is that we do daily, it's quality control. And then we have quality assurance. And then a subtype of that is external quality assurance. Quality assurance in general means that it includes anything possible, any measures that assure that quality is going to be delivered in whatever that is. And in this case, it's a laboratory medicine and biomarker testing. So it even includes like licensing of pathologists who are going to read out the slide with the results for a certain biomarker, and maybe licensing of technologists who are going to be involved. So it literally includes many, many things that people usually don't think about. So external quality assurance is one of those, like everybody thinks we know what is external. Yes, you know what is external. It's external, so it's not internal quality assurance. And what it can involve is also very broad. But usually when we talk about biomarker testing and external quality assurance, then usually people first think about proficiency testing. And that means when laboratories are challenged to perform one of their routine tests that they do all the time and provide these results to external program, organization, agency, whatever that is. But it's also another aspect of external quality assurance and could be proficiency testing, not necessarily. It's when laboratories compare their results to some reference lab and they're not applied. It's not even proficiency testing. They're just like when they're developing the assay, they want to be sure that they develop properly the assay. So they will be sending, material between the laboratories, whether it's molecular assay or whether it's some other assay, it doesn't matter like what type of testing that is. It's just sending the samples between the labs and comparing the results. That's also external quality assurance. But primarily when you think about EQA, we primarily think about proficiency testing, and that is organized by some program or agency.
Mm-hmm. So why is there an overall need for this EQA when it comes to using new and also existing assays for testing biomarkers in oncology?
It's very important. We discovered first with diagnostic biomarkers. So that those are biomarkers that we use to make a diagnosis. And it, again, does not matter the technology. Is it a biochemistry test or is it immunohistochemistry test, staining slides, or is it a molecular assay? It doesn't matter. For all of them, we discovered relatively early for diagnostic assays that each laboratory has trouble knowing how the assay is calibrated and whether it's producing proper results if there is no kind of external stick or yardstick or some measurement from outside that like, we are all on the same level, whether the testing is properly calibrated and whether it's harmonized with other laboratories in the country. So it is very important, even more so than for prognostic and predictive assays for, let's say, immunotherapy or targeted therapy in oncology, where stakes are huge. You really want to use this assay to properly stratify the patients, whether they're going to receive some therapy or whether they're going to be denied that maybe some new therapy comes up and then they don't qualify. So you really want to be sure that you're not producing false positive or false negative results because they can do patient harm. Therefore, because the stakes are so high, we have to very early today, we cannot wait like a year or several years to be sure that we are doing the right thing. We have to be sure that we are doing the right thing from the start. And proficiency testing, external quality assurance, it's not the only measurement of quality. And one would even argue whether it's really reflecting your practice, because sometimes you get the results that are not really reflective of your daily practice and for various reasons. And there may be one assay that is one off and it's saying that you didn't do well, but you're actually doing a perfect job with patients. So it's not everything is in the external quality assurance, but it is important because when proficiency testing exists and when it's in place, it tends to make laboratories focused on their performance and the assays. Even though you can say, well, of course, why are they not focused anyways? Because it's patient care. No, they are. But this brings another level, another step at which the whole lab, and that means technologists, managers, professional staff, PhDs and pathologists, and everybody is more focused on that and more closely monitoring the performance.
Yeah, that makes sense. So when you are implementing these schemes, which ones are typically used when you're testing a new assay, and which ones would you use if there's an existing biomarker assay that you want to ensure EQA?
Now you're bringing up a very interesting question, because historically, EQA and proficiency testing would not develop proficiency testing ahead of an assay being well established. So now, knowing that stakes are high, we try to actually develop some sort of proficiency testing or means of communicating what results should look like very early, even before the drug is approved and even before the testing actually has been mandated by either funder or Health Canada. And that is actually a new aspect. This is not what typically proficiency testing does. When proficiency testing starts, we usually call those pilot runs or educational runs, because we are introducing something for the first time, and we do not expect laboratories at that point to be totally proficient. We will be very happy if everybody is right on the spot and everything looks great, but it's not a real issue if laboratories are not performing the best, because what happens is you realize the testing actually for the patient didn't start yet. We are all in the development stage. So at that stage, this is the time when we want to intervene, and this is where we can do the best, help the most laboratories to develop proper assays and or to show that they have developed proper assays. So that component very early is very important. And when you're asking like what type, I mean, we just call it different runs, but generally, depending on the assay, there are different things that we can test for. So we can, and we call what we are testing for, we call test performance characteristics. So we can test the components of the assay itself, technically of the analytical phase. We can look at, for example, immunohistochemistry and immunohistochemistry protocols. We can look at whether assay is, does it have proper analytical sensitivity and specificity? What is the diagnostic sensitivity and specificity? What about reportable range? Are you able to demonstrate all the, range of expression of the marker that is in question, and etc. So readout is another component that we recently started. It's generally readout by the pathologist, but as technologies evolves, this soon may become more domain of artificial intelligence. But for now, it is mainly pathologists who are reading the slides of the IC slides primarily, and also like FISH results, like fluorescent in situ hybridization. Those are read by technologists or by pathologists. So this readout component, when it's done by human rather than an automated reader, like in some other assays, let's say nephelometry or ELISA. For example, in ELISA, we have colorimetric reactions, so the change of color is detected by automated reader, and then you get some number to that or result, and then you do the interpretation of that result. And this is what pathologists are serving instead of these automated readers when they're stained slides or FISH. So pathologists are in a very difficult position because now they have to perform as close as possible to being perfect and performing the same every time. Pathologists need to have really high intra-observer reproducibility as well as inter-observer reproducibility, so their results need to agree with expert results or expert consensus results. And that's one aspect that has been that we try to develop recently, because there is a demand because of the high complexity of the readouts that are present with some of the newer markers, especially PD-L1 assays. We have various different readouts, and pathologists need to become proficient in all of them.
Mm-hmm. That's a lot for them to take on, I'm sure. I'm just wondering also then, when you have an existing assay that's used for a new treatment, so for example, expanding current PD-L1 assays for a new indication, such as in breast cancer, then how do you implement EQA there?
Well, this is one of the good examples. How do we implement EQA, as I said, because it depends where in the developmental stage this assay is. Very early, before it actually the drug was approved, there was a good idea about that. Actually, we will need to have proficiency testing for that. So at that stage, that pilot run or educational run would be appropriate. And at that stage, also developing a readout, what we call modules, those are sort of runs. So developing online tools to test pathologist proficiency to do the readout of the that would like a PD-L1. We think about triple negative breast cancer, and for that triple negative breast cancer, we would need then identify the cases and stain these cases with PD-L1, scan them and put them in the module for pathologists to access it and to compare themselves to experts as well as their peers, because at least in our program, these readout modules work like that they provide to the participants the results of the expert consensus and also how they compare to everybody else who has taken this assay before them. So there is also peer comparison.
Mm-hmm. And how is that process different than performing EQA on a completely new assay?
Well, that would be for completely new assay, preparing that modules before the approval. And for the new assay, as I said, the runs are for technical aspects of the assay, in a sense, for the protocol itself. And we are talking about PD-L1, so we are talking about immunohistochemistry assay. So for that assay, for the technical component, there is a difference between this early development and routine testing. Early development actually enables participants to engage more closely with the EQA provider like CBQA. And at that stage, it's possible that they do the tweaks and improve the assay, and there is no judgment. And at that stage, also, it's important, are we going to help laboratories do actually full validation of their assays? Because for validation, they will need number of cases, and they may or may not have actually enough cases in their laboratory to do the validation. So we may help with validation and introduction of the new assay by providing additional cases for them. And not necessarily that participation in EQA can replace the process of validation. It would be too easy, actually, not too easy, I shouldn't say that, but it would be simple if that was the case, but it cannot be, because validation is more than just participation in EQA. Validation process, depending on what type of assay that is and whether the assay is companion diagnostics approved by regulatory agency like Health Canada or FDA, or it is your laboratory developed assay, components of the validation will be drastically different. And then in that view, like how these components, what they include, we can't find a place where EQA can do part of that, but certainly EQA will never cover all the bases for validation, especially not for laboratory developed tests or LDTs.
Mm-hmm. So thinking about, this example where you have an existing assay, let's say it's already been validated and you have EQA schemes already developed for it, but then let's say that assay is then people want to use that for a new indication. So, for example, these immunotherapies that are being used for a variety of different indications, what needs to be done to make it applicable to those new indications?
This is a very good question. This new indications and using it for new indications is called repurposing. And repurposing is well known to pharmacological industry that develops new drugs and want to actually use some of the older drugs for new purposes. And if you closely follow what regulatory agencies ask from pharmacological companies to do to repurpose the assay, you will see that they are asking for a clinical trial. That means there has to be clinical validation for that drug to be shown that you can use it for that new purpose. So how does that apply to then laboratory medicine and the test? If you want to repurpose the test, then you have to also validate. And to validate clinically, it's not feasible, because to have a clinical trial for example, you develop now LDT, laboratory developed test, and you want to use that laboratory developed test for this new purpose. So you develop it for one purpose, and maybe it works perfectly for that one purpose. Or maybe let's just assume it does work perfectly. And now you want to use it for another purpose. You have to then show that this is the valid assay to use for that purpose. Just having a name that this assay is PDL1 assay, it's not helpful, because any biomarker can be performed by many different biomarker assays. And every assay is defined not only by the biomarker, but also for its purpose. So you can use PDL1 for one purpose, like for lung cancer and for pembrolizumab, or you can use it for another purpose for upper GI tumors and for nivolumab in combination with chemo. And then can we use the same assay? So that's what you're actually asking. Can we use, because EQA programs, they're also not testing that in kind of metaphysical way, just biomarkers. They're testing biomarker assays, and because purpose is intrinsic part of that, you cannot disconnect purpose from the PDL1 assay. Once you change that purpose, you have developed a new assay. Maybe you don't have to change anything technical about that assay. Let's say we're talking about PDL1. So maybe you don't have to change antigen retrieval, antibody incubation time, maybe none of that. You have to check. Maybe everything will stay the same, but you don't know that until you actually show that conditions that you use for one purpose now are also going to work for that new purpose. And published literature may help. You may say, okay, I read that these two assays are interchangeable. like say in Blueprint, phase 2 said, and several other papers said that 22C3 farm DX is interchangeable with 28A, or even that SP263 can replace any of these two, that is good enough. But actually, those are not validations for your laboratory. Why not? Because in those studies, generally, people, what they compared for, they broadly compared analytical similarity between the assays. They did not look at specifically the errors, and where they did, when they compared diagnostic accuracy, they compared for the certain purpose, because it's not possible to compare accuracy without comparing for the certain purpose. So if your purpose has not been addressed, that for which you're developing in published literature, that means actually there is no data on that you have to provide that evidence. There's no published evidence or data that you can do that. So you have to do it yourself. And even if there is published evidence that somebody else did it in their laboratory, when any laboratory is introducing a new assay, or in this case, new purpose, you have to show that actually you are able to do it. So one way or the other, you have to do either technical validation, which means it's everything else has been proven in literature and everybody knows that this should work, but yet you still need to do technical validation and you need to follow the rules for technical validation. So you cannot go away from that. And if the readout is different for this new purpose, then your pathologist or artificial intelligence algorithms or whatever, they have to show that they actually also have high accuracy for this new purpose. And then the testing can start and it can be reported. So those are the big issues. And let's say there hasn't been published evidence. So what do you do then? Well, can you start a clinical trial to show that it can be used for this purpose? No, you cannot, obviously. So what do? We have something that we call, in the concept of that, is indirect clinical validation. Is it good as clinical validation in clinical trial? No, it isn't. It isn't the same level of evidence quality, but this is the best you can do. And sometimes even FDA and Health Canada approve such validations. And if they do, then we know it is okay to do that. So let's say you do indirect clinical validation, and you have to do, in such cases, you have to just use more cases than you would do for technical validation. And you have to be certain to include good number of positive, negative, to include the entire reportable range or whatever. All of these things are published in the literature and available to people to follow. So, but it has to be done if nobody else has done it before you. And if they did, you have to see how that published evidence applies to you. And if it does, as I said, you still need to do technical validation, or at least readout validation for pathologist or image analysis or artificial intelligence.
Yes. Okay. That's very interesting, because it's almost like you're starting again with a completely new assay in a sense.
Yes, it is. The only thing is we already know how this works for another purpose. We already know proximate conditions in the lab, what you need to do to get good signal to noise ratio, with your tissues. What controls have you used? Now maybe you have to use different controls because different purpose for different tumors and different cutoffs may require different types of controls. So everything has to be reconsidered.
Mm-hmm. Yeah, that's a big job for sure. And with all the different sort of new possible indications for a lot of these immunotherapies, I'm sure it's a big task, but it has to be done properly for sure. So
there is one exception to this, actually, maybe we should mention, because mainly what I'm talking about, mostly it is about LDTs, and especially if when you have this companion diagnostic and it's tightly controlled, and we count on it that it's going to be reproducible. So in that case, for example, let's say you were using, when we talk about triple negative breast cancer, you were using already 22C3 for lung, and now you want to use it for breast. You need to validate it assay. This assay has been already repurposed in the clinical trial. So you don't have to do that part, you see. Now, that's the difference. Because if there is a clinical trial that repurposed the assay, and assay has not changed whatsoever from the clinical trial to your laboratory when you receive it, buy it from the company, so that's the same assay, then you don't need to clinically or indirectly clinically validate because it has been clinically validated. What you need to do you still need to verify the assay itself, that it performs as it usually does, and that's done by reading the inserts that come with those kits. But you still need to validate for this new purpose pathologist readout. You do need to do that part. Mm-hmm. Again, there's a huge difference, because I have heard that in some places people thought, okay, it is companion diagnostic, but I still need to validate. So we're talking about 50 positive, 50 negative cases for indirect clinical validation, which you don't need for the IHC assay component. You don't need to do that, but you will need now to validate this number of cases for pathologist readout.
Right. So it's more about the readout than the assay.
Yes, but that is the only exception.
Yes.
And if this has not been used in a clinical trial, the moment actually you take that CDX and use it for the purpose that is not listed in its specifications or approval by regulatory agency, that moment you make it laboratory developed test. It doesn't matter that it comes prepackaged in that box. It doesn't matter that it's frozen conditions maybe on your instruments and so on. It still becomes LDT because you have changed the purpose for which there is no clinical trial.
Yeah, that makes sense. That's about having the clinical trial data to validate it.
Clinically, yes.
Yeah. So just thinking about how we're doing in Canada in general with all of this to manage, are there any studies that have looked into EQA to see how Canadians are doing in this?
Well, yeah, there are actually. Canada is one of the leading countries that publishes results of EQA and proficiency testing results. And there are some Canadian Immunohistochemistry Quality Control, CIQC, that stopped existing in late 2019, but as long as it was there, published a number of papers that were really instrumental globally to give a lead to others what these results mean and where laboratories are, how they perform, and so on. And also to contribute to the concepts of external quality assurance, like what can or cannot be looked at, how much this data is worth, and so on. Since then, the CIQC split into Canadian Pathology Quality Assurance with its location in BC, and Canadian Biomarker Quality Assurance with its location in Saskatchewan, in Saskatoon. So from there, these two organizations are trying to continue with a little bit different focus on what parts of proficiency testing they cover. And there are at least good plans to publish a number of studies from CBQA. I'm not certain for CPQA what their plans are, but there will be more studies coming from CBQA very soon. We're ready soon to submit a couple of them for publication. So we do know, we like to publish the studies before, so they're available and they're transparent in relevant journals. What do we know internally when we do audits and look at it? We know that similar to NordiQC published data, about 30% laboratories will have suboptimal results, generally speaking. Whether what these suboptimal results mean, whether they're total failures or not, that's a different thing. And the total failures are actually rare, but suboptimal results are also not good. So what happens then is that CBQA, I cannot speak exactly for CPQA because I'm not sure exactly how that works, but we'll work with laboratories to try to help them and resubmit materials for testing once they tweak their protocols. And actually, before they actually change anything, we have to make sure that that result that they got, is it really representative of their practice or not? Maybe just repeat testing will show that this was just a failed slide, which can happen because we know that about 2% of all testing material routinely will be just failed slides. And yeah, I mean, there are mostly good results, but sometimes they're not perfect. And when they're not perfect, EQA programs in general, at least in Canada, try to work with laboratories to get it there.
Mm-hmm. Yeah, that's there's definitely a lot of room for growth then. So speaking of that, what are some of the key barriers to performing EQA in Canada, and how can we overcome these?
This is the key question, if anything is important in today's conversation and discussion that we have, is this one, because we have huge barriers to EQA in Canada. And the major one is that health is provincial. And because of that, every province regulates its own health rules and EQA participation, quality, and so on. And that is, at this point of precision medicine, not a good thing, because Canada is not a large country, and territorial is large, but we, by population, number of laboratories, and especially when you split it further into provinces, some provinces are just too small to have all that it takes to run proper proficiency testing program. So they don't. So they participate. And so where they participate, and that's where we are failing too. There are no rules. There are no national harmonized rules and approach to quality for biomarker testing. So that's the greatest issue. And CBQA is just in a phase of now initiating a national summit for all stakeholders now. Patient advocates, Ministry of Health that is doing the funding, and they have their committees for quality, professional organizations such as Canadian Association of Pathologists. I think that academia in general, and then any EQA programs that currently exist, we have to get together and we have to move it to the point where we have national approach to quality. So this is the greatest barrier that we have, is that we have a fragmentation of quality concepts and rules throughout Canada, depending on the province. And we have to stop that. We have to have unified approach to quality, and we have to also have unified approach like what AQA programs actually should be doing and how. Because right now, that is not controlled by anybody. What AQA programs like CBQA may decide one day, we're going to have 3 runs of these or non-runs. Nobody is looking into that. There is no regulation. And programs do what they can now because of funding that is extremely limited. Actually, this funding doesn't even exist in the current ministry budget for participation in EQA. So individual pathology departments and laboratories have to pay for participation. And sometimes it's not even possible to charge laboratories because, let me tell you, some of the schemes for molecular markers are so expensive that having maybe 10 or 20 laboratories in Canada that can participate, that can never pay back what it takes to put that together, a run like that. So right now, it's heavily dependent on industry funding. And CBQA is very grateful to industry funding to give us educational and operational grants. But it shouldn't be that way, that industry, we always have to go to industry. There had to be some sort of a budget for this in whole Canada. I'm sure we have that much money because it's not even in the big scale. We are talking about very little money compared to how much precision medicine costs in general. This is just close to nothing compared to the price of drugs. So it is actually very cheap and cost effective from the government perspective and professional perspective. And we should go there and do that as soon as possible.
Yes, that's a good comparison to the price of drugs in general. So, just looking at how people can reach out to get more information about EQA, what external bodies and resources exist for laboratories that are looking to improve the quality of their assays?
Today, there are, as I mentioned, 2 quality assurance programs for biomarker testing, and that is Canadian Biomarker Quality Assurance and Canadian Pathology Quality Assurance. So they can reach out and look at with both, and they can participate in both if they wish to do so. And we see it's not mandatory. That's what I also want to say and forgot when you asked me what are the barriers. The barrier is that proficiency testing for this type of biomarkers, when it's so much in stake, about stratifying the patients for therapies, that has to be mandated. And right now it's not. Some laboratories decide to participate in one program or the other. They may not participate in some of the proficiency testing for biomarker assays because maybe they're not available at all. Not in Canada, maybe not in the world. And the traditional approach for EQA, that it takes a year or longer to develop proficiency testing for certain biomarkers. So there may be no biomarker EQA that they can participate in. But for now, in Canada itself, as I said, these are two programs. And CBQA also has a branch for pathologist readout. So it's called cbqareadout.ca, and that's actually the address of that page. But in addition to that, they are, and they do, not only that they can, but they also do participate in international EQA proficiency testing runs, and that includes both those that are from the United States, but also from Europe. There's a good number of laboratories that participate in Scandinavian quality assurance program NordiQC that provides really high quality for mainly diagnostic biomarkers and very few predictive and prognostic biomarkers. And then there is College of American Pathologists runs where a lot of laboratories in Canada, maybe not a lot, but a good number of laboratories in Canada subscribe to and participate in their EQA-PT. And with that, that also includes now, especially for molecular runs, a lot of runs are going to be done from there because CBQ just started to develop molecular proficiency testing runs for Canada. And there may be also in UK, like UK NECVAS and similar from UK, there will be also proficiency testing for molecular. And most of the laboratories actually, especially molecular labs, they know this because they didn't have any other choices in Canada until practically this year. So they had to go out if they wanted to participate in any, proficiency testing. They know very well about these international programs. For immunohistochemistry, also College of American Pathologists and NordiQC are well known to laboratories.
Well, this is very helpful. Thanks so much, Dr. Torlakovic. And is there anything else that you want to add on the topic before we conclude?
As I said, your question about barriers, that was, in my opinion, the most important one, because as precision medicine evolves now, we are at a stage when we can see for all the clinical trials that are going on that biomarkers, the number of them that is required for precision medicine is not going to go down. It will go up. And knowing that, we know that we are not ready to individually in Canada, we are not ready to provide all the proficiency testing that needs to be set up in place for that. And the only way to go is to have a centralized, approach and central hub that will enable us to pull all the brains together, different profiles of expertise, and then to set up a system in place that is going to coordinate between clinical trials and industry that is developing these assays to the end user, that pathologist that is sitting there reading the slide, or in molecular lab, that results that are coming out from NGS or some other testing. There has to be streamlined, connection and understanding, transparency. We have to develop that as soon as possible. Otherwise, it's not going to be good for the patients because we are not going to be sure whether the quality is really at the level it should be. Are we developing these assays with delays so testing will not start in time when we want to start at a high quality and so on? So these are huge issues. So I hope that we will be successful in getting to that summit, all the stakeholders, and they will listen and they will all agree that, yes, this is the highest priority and let's go and do that.
Well, thank you so much for discussing this extremely important topic with us. And we're very happy to have such an expert as yourself to discuss this with. So thank you so much for joining us.
Thank you for having me.